Okay, hi everybody. Hope you're doing well. So, welcome to all. Today, we'll be continuing with our next session on clinical therapeutics pertaining to the central nervous system. I hope I'm audible and I hope that my slide is visible. Yes?
Yes, ma'am.
Yes, ma'am.
Okay. So, today, before we proceed, this is an important part for the exam, clinical therapeutics. It covers a good amount of your scoring system, almost 40% of the questions. But nevertheless, if your theory is strong, if you have studied CNS, RS, CVS well, then automatically you will be able to answer the therapeutics question. It is just using your previous knowledge in the question answer format, in a case discussion format. But yeah, therapeutics is important. It constitutes about 40% of the questions as per the new OPRA curriculum. Okay, is it clear? Okay, from lab to bedside. I think you all must have heard that saying in pharmacy as well, in PharmD. From lab to bedside, we do a research in a particular laboratory, then the medication is undertaken in clinical trials, and finally it is applied in the hospital setting, that is the clinical bedside settings. So let's come to Alzheimer's disease. Alzheimer's disease is also called as progressive dementia. So last time we mentioned that's dementia when it is present in the early stages, it's not Alzheimer's. Dementia is just forgetfulness. That is to do with memory impairment, and this will occur in most of the individuals who have crossed the age of 65. This might occur with almost everybody who's there on this earth if they don't take care of their health and after 65 years. Okay, so dementia, the thing is, there are two types of memories, that is long-term and short-term memory. So to begin with, there is a loss of short-term memory, and as the disease progresses, even the long-term memory gets affected. Okay, so once in the initial stages, maybe once we are above 65, we might just forget where we kept the pen, where we kept the bottle, or maybe what we ate for dinner or lunch. That is just the beginning stage of dementia. But as it progresses, Alzheimer's patients, they even forget their own family members. And that is the most distressing part. So I came across, during my clinics, I came across cases where there was a wife who couldn't even recognize her own husband or her own family members. But somehow she could recognize the caretaker. So she wouldn't allow anybody to come close to her, because she couldn't recognize only this was her family. All she knew is that this caretaker has been appointed to help me. That's it. It is a very distressful situation. It looks easy, but for somebody who's going through it, it's a distressful situation, and also for the family members, it's a difficult situation. So anybody who's facing dementia in the early stages, please work on memory enhancing techniques, cognitive behavioral therapy, the psychogenic techniques, that is meditation, working on reflection technique. So I propagate this a lot. This is just some extra knowledge I'm giving, for you, because I don't want you all to be in this state when you are elderly, 65, 70. You should be self-sufficient. Okay. So that's reflection technique. Towards the end of the day, just close your eyes. Before you sleep, about 10 to 15 minutes, just reflect upon the different activities you did throughout the day in a chronological order. Okay, what you did from morning to night in a chronological order. After the sessions, after you finish your chapters or after you finish the lectures, you should follow the same. Close your eyes for 10 minutes and reflect what was covered. By this, you will be able to retain much, much better. Okay, another way to work on enhancing and keeping the mind active is doesn't mean you keep hyperactive, always on the go, but it means having phases of activity and phases of rest for the brain. Okay, so meditation helps in those phases of rest. And then comes activity once you retire after 65 years of age, or maybe if you decide to take early retirement in 50s, that time you should work on certain cognitive enhancing techniques such as solving puzzles, crossword puzzles, playing a game of chess, something that will make your mind work. So your mind is not completely stopping to work. It is acting analytical, but not over analytical. All right, so let's see how do we diagnose a case of Alzheimer's disease. Let's come to your exam portion. There is mild Alzheimer's, moderate, and severe Alzheimer's. So, mild Alzheimer's, moderate, severe, this is classified based on a subjective scale, that is MMSE scale. Okay, this is called as mini mental state examination, MMSC. In fact, in majority of the CNS disorders, even in Parkinson's disease, we have scales to diagnose it. So, it's very difficult for us to say, okay, this patient is forgetful and diagnose it as Alzheimer's. So this scale has certain set of questions, and if majority of the answers are such that this patient is forgetful, then it will be a case of Alzheimer's disease. So rather than asking one or two questions, these are standardized scales which have 20, 30 questions. We ask the patients, and if majority of the questions indicate forgetfulness, now we say this patient has Alzheimer's disease. How are these scales made? So these scales are made by expert researchers. They research on it. They undergo a clinical trial. So the scale before coming out in the market, it was tested maybe in thousands of people or lakhs of people already in the clinical trial phase. And then it was deemed apt to be out in the market, to be out in the clinical practice, to be used for every patient. Okay, so what's a case of mild Alzheimer's disease if the MMSE score is 26 to 18? Okay, so it's on the higher range, 26 to 18. That means most of the questions this patient is able to answer. Okay, so this is just a case of mild Alzheimer's disease. Patient has difficulty remembering recent events. I told you short-term memory. Ability to manage finances is self-sufficient. Ability to prepare food and carry out other household activity, that declines. Okay, so the patient is self-sufficient, but there is a decline in these activities. Okay, the ability to manage finances is there, but not as much as it was before. Able to prepare food, but this activity has declined. May get lost while driving, can forget directions because of short-term memory issues, recent events, begins to withdraw from difficult tasks and to give up hobbies, may deny memory problems. So these patients are often in denial. They say, no, this thing I forgot. I just forgot the direction today. Otherwise, I remember everything else. Okay, so diagnosing at an early stage becomes important. Then moderate Alzheimer's, if the MMSE score is between 17 and 10, 10 to 17, you can say, because 18 onwards is mild. Here, the patient requires assistance with daily activities. So I told you in mild case, the activities declined, but the patient was self-sufficient. Over here, the patient might require, in moderate cases, some support from the caregivers or family members. Frequently disoriented with regard to time, date, year, and season, recall for recent events is severely impaired, may forget some details of the past life and names of the families and friends. What was done in the past, they may forget a little bit of that, and names of the families and friends also. Functioning may fluctuate from day to day. Sometimes they are completely normal, and sometimes they are totally forgetful. Patient generally denies these problems again and may become suspicious or tearful. Okay, loses ability to drive safely and therefore needs somebody with that person. This person should not drive alone. Agitation, paranoia, and delusions are common in this patient. Paranoia is extreme confusion state. Okay, it's a state of extreme confusion. Agitation is getting aggressive. Delusion is going to be, just feeling that something is there, which is not actually there. So it's a kind of delusion. They are living in a world of delusion, is what we call. Dilemma, correct. Yes. Okay, then we have severe Alzheimer's disease, where the MMSE score will be almost negligible, almost 0 to 9 points are really less. The patient has scored really less. And in this, the patient loses ability to speak, walk, and feed self. There is incontinence of urine and feces and requires a 24 hours day care and 7 days a week. Always the caregiver has to be there with this patient because speech is also actually based on memory. As kids, we don't know how to speak when we are born. Slowly, slowly, we learn that. But as we progress, we maintain that speech because that thing is there in our long-term memory. How to speak is there in our long-term memory. How to walk is there in our long-term memory. In case of severe Alzheimer's disease, there is a washout of the long-term memory as well. So these basic activities also one forgets how to do. Okay, so how do we treat a case of Alzheimer's disease? First is non-pharmacological therapy. So we address the behavioral issues, that is, address the sleep disturbances, wandering, incontinence, agitation, and aggression. Cognitive behavioral therapy will help to reduce this agitation, aggression. Incontinence, so one has to be taught pelvic floor exercises, to maintain this incontinence, to overcome the incontinence. And this patient might be wandering, have sleep disturbances. Sleep hygiene has to be taught. The patient, if seen wandering, should have some kind of support. So these are the behavioral interventions. Educations, educate patients and caregivers on the disease progression, treatment options, lifestyle changes, legal decisions, and quality of life. Okay, educates the patients and also the caregivers. Some caregivers begin to say, no, we don't want to treat this patient. Let it be. All this behavior intervention does not work. He will be fine after a few days by himself. It doesn't happen that way. Psychogenic interventions, cognitive behavioral therapy, behavioral interventions are important at an early stage so that the patient does not require pharmacological treatment at a later stage. Okay, so educate the patients and caregivers on disease progression, treatment options, lifestyle changes, legal decisions, and quality of life. Then there are lifestyle recommendations that's given by the Alzheimer's Association. So one has to stay physically, mentally, and socially active. Okay, it shouldn't be that this patient is giving up completely and saying, no, I'm good for nothing. I cannot do the regular activities. No, at least one has to try to stay active. Follow a low fat, low cholesterol diet that is rich in dark vegetables and fruits because these also have a memory enhancing effect. Okay, and antioxidants. Oxidative damage can further affect the memory and further worsen it. So we use dark vegetables, fruits, green leafy vegetables. Why? Because of the antioxidant effect. And manage the body weight. If the individual becomes overweight, lethargy seeps in, and the ability to stay physically, mentally active declines further and worsens the disease. All right, so let us continue. Treatment options for cognitive symptoms in Alzheimer's disease. What is the literal meaning of the term cognition? What comes to your mind when you think of cognition?
Related to memory.
Memory, related to memory. So if we say that somebody's cognitive score is high, that person's memory or thinking, analytical skills are very good. Okay, so let's see. In mild to moderate disease, we consider therapy with a cholinesterase inhibitor. Examples include this we've done when we were doing ANS as well. Okay, so that's donepezil, rivastigmine, and galantamine. What we do is we titrate to recommended maintenance dose as tolerated. So there is no fixed dose that's given to every patient. We always start with a low dose. I think it's around 5 to 10. And then slowly, we titrate it to an elevated dose if the patient is not responding, or we down titrate also. From 5, it can come to 2 mg also. Down titration and up titration, depending on the symptoms of the patients. In moderate to severe disease, consider adding anti-glutamatergic therapy as well, which is memantine. If you have heard of memantine, memantine is also helpful because of anti-glutamatergic activity. Titrate to recommend maintenance dose as tolerated. Alternatively, consider memantine or cholinesterase inhibitor therapy alone. Okay, sometimes even either or used alone, it's helpful. Behavioral symptoms may, however, require additional pharmacological approaches. Generally, if the patient is not well controlled, we require both together. That is a cholinesterase inhibitor along with anti-glutamatergic therapy, that is memantine. Okay, one more thing is that in Alzheimer's disease and also psychosis patients, I have seen paranoia more common, a state of confusion such that this person is getting confused and starts feeling that the people around him are wanting to attack him. That is a level of confusion. Even if somebody is trying to help them, they start feeling this person is here to attack them. So that feeling of distrust and mistrust is quite prevalent in such patients. So like I told you, that was a case of a husband, a wife, a mother and children. So since the children were not there staying in the house, um, and they were not in touch since a long period. She got Alzheimer's. She couldn't recognize her own children once they came back to meet her after a year. So that time she was saying that I think they're going to attack me and stuff like that, although there was nothing like that. So there is extreme sense of confusion and a sense of persecution, as if this person is going to hold me captive or is going to be there to harm me. Okay, so that sense is also present in these Alzheimer's cases and also in cases of psychosis. Okay, now let's come to the doses. So, like we discussed, for donepezil, it's generally started at a dose of 5 milligram daily at bedtime. It's available as tablet or oral disintegrating tablets as well, ODT that we call. And starting dose is going to be 5 milligrams daily at bedtime. The maintenance dose can be 5 to 10 mg depending on the progress of the patient. If the patient is progressing and getting worse, then we need to escalate it to 10 mg. If the patient is getting better, I have also seen that 5 mg has been reduced to 2.5 mg, half the tablet instead of full tablet. But that scenario is very, very rare. Mostly it continues at 5 mg, or maybe it's escalated to 10 milligrams. Okay, as such, no effect with food if you take donepezil, and the half-life is going to be as long as 70 hours. Okay, so definitely since the half-life is so long, it's only once a day dosing and not BD or TDS. Okay, let's come to rivastigmine. Rivastigmine is available as capsule, oral solution, or even as patch. It is given at a dose of 1.5 milligram twice a day. And if we use the patch, then it is given as 4.6 milligram per day. Try to remember these doses because these are easy to remember. Okay, maintenance dose may be 3 to 6 milligram twice a day or 9.5 milligram per day patch. If the patient is not responding well, the maintenance dose may be an elevated dose. This should be taken with food. It's absorbed better if taken with food, and the half-life is only 1.5 hours. Okay, that's why it's preferable to take it twice a day. In some rare scenarios, I've also seen prescriptions containing thrice a day dosing of rivastigmine, but all in all, most of the times, twice a day regimen is the most commonly acceptable one. Galantamine is available as tablet oral solution or even extended release capsule formulations. Okay, ER, extended release formulations. Dose is similar to donepezil, 4 milligram twice a day, but this is twice a day. And 8 milligram daily, once a day can be given if given as an extended release formulation. It can be escalated if the patient is not responding well. So this should also be taken with food, and half-life is going to be 7 hours. All right. Now the protein binding of donepezil is going to be much more, almost 96%. Rivastigmine and galantamine, it's quite less. Okay, so in this case, what happens is if there is a patient who is having less proteins in the body. Ideally, 96% is protein bound and 4% of donepezil is present in circulation. But if I say this person is deficient in protein, automatically, instead of 96%, maybe only 92 or 93% will bind to the proteins. And instead of 4% being available in circulation, 8% will be available in circulation. It's getting double. So in such drugs which are highly protein bound drugs, it's important to measure the protein levels of an individual's albumin globulin ratio, which is there in the liver parameters, blood test of liver parameters. Okay, and metabolism, it is a substrate of the cytochrome 2D6 and cytochrome 3A4. It's activated, metabolized by glucuronidation. Rivastigmine, it's cholinesterase mediated hydrolysis, and galantamine is also a substrate of CYP2D6 and 3A4. So the drug-drug interactions will be more with donepezil and galantamine rather than rivastigmine. So if there's a patient who is on polypharmacy, multiple meds, it's good to go with rivastigmine, given lesser drug-drug interactions. Donepezil is eliminated by renal route, and for rivastigmine, also renal route is the major pathway, but even liver, both liver and renal route. And for galantamine, also renal elimination is most prevalent. All right, now let's come to the drugs used for non-cognitive symptoms of dementia. Okay, non-cognitive are going to be the ones not associated with memory. I told you other symptoms, even psychotic symptoms would be there in Alzheimer's disease. Aggression, paranoia, all these symptoms, for that we use antipsychotics. Haloperidol, olanzapine, quetiapine, risperidone, ziprasidone. Which ones among these is a typical antipsychotic? Yeah, it's just haloperidol. The others are going to be a atypical antipsychotics. So broadly, the antipsychotics are classified as typical, atypical, or first generation and second generation. So typical are also called as first generation, the older antipsychotics, and atypical are also called as second generation, the newer antipsychotics. So haloperidol, chlorpromazine, all these come under typical antipsychotics, the older ones. And the remaining that are given over here are the atypical ones. Okay, then we have antidepressants, again for the aggressive behaviors and for feelings of depression, like insomnia, hopelessness, anhedonia. And what is the meaning of anhedonia? Anybody? Okay,
Lack
so
of interest.
lack of interest in anything. So they're generally not interested in anything. Just like they just like to sit in one corner and be with themselves. That is anhedonia. Lack of interest in study is one thing, but these are the patients who have no interest in anything. They don't like anything. Okay, that's the meaning of anhedonia. These patients might also get suicidal thoughts, agitation. So all this is controlled by antidepressants. So in the antidepressants, I think you are aware it's covered in the CNS previously with you. Citalopram, escitalopram, fluoxetine, your SSRIs, paroxetine, sertraline, venlafaxine, trazodone. All these are examples of the antidepressants. Okay, let's come to other medications that are used in dementia, Alzheimer's disease. Anticonvulsants, such as carbamazepine and valproic acid. This dose, I think you're already aware, we've done an anti-epileptics. Carbamazepine dose range is generally 200 to 600. Valproic acid would be higher, 500 to 1000 milligram per day. Okay, these are mainly used to control the agitation or aggression. Okay, that's why you also see carbamazepine is used in bipolar disorders, which we will come to now, to control the extreme activity or mania symptoms. Okay, let's come to the Q&A. A 70-year-old female diagnosed with Alzheimer's disease is started on donepezil. What is side effects should be monitored in this patient?
Bradycardia.
Yes. So what we'll do, no, absolutely correct answer. We'll type the answer in the chat box because if one student answers, no, others stop attempting also because now they know, no, the right answer. So we'll type the answers in the chat box. The answer is bradycardia. That's option B. Why bradycardia? Anybody would like to say? Now you can unmute and answer.
Because acetylcholine is responsible for bradycardia.
That's right. Correct. Cholinergic side effect. Next question. A 72-year-old male with Alzheimer's disease is prescribed donepezil for cognitive symptoms. After 2 months of therapy, he complains of diarrhea, nausea, and fatigue. I think you should be able to answer this also. What is the most likely cause of these adverse effects? Yeah, easy, correct. All are correct. Option A, that is donepezil related cholinergic side effects, is the answer. It's an anticholinesterase, no? So the breakdown of acetylcholine won't happen. That's why ECH levels will increase and the cholinergic side effects will happen.